Peterborough's community radio station, Salam Radio, 106.2 FM.
Assalamu alaikum and welcome to Salam Radio 106.2 FM. You are listening to Faiza from the Raham Project and your local midwife. I'm going to be sharing some midwifery insight with you all today. If you are interested in getting in touch on the show, please remember that you can call or text us on 017 33 602 133 or email us on info@salamradio.co.uk. You can comment on the Facebook thread at Salam Radio, which is also going to be shared on our Raham Project page. Now, I've got a very special guest with us today, and I'm so excited about today's show. I'm going to read a little bit about our guest just before I get her to say hello to you all. So we have Lisa, who is a qualified advanced clinical physiotherapist. She specializes in women's and men's health. She works for Northwest Anglia Foundation Trust and recently led the implementation of the Perinatal Pelvic Health Initiative. She believes in empowering women with the knowledge to understand their own bodies and care for themselves, and pelvic health is a key component of this. Liesl, welcome to our show. And we're so excited to talk to you about pelvic health. So I guess that's where we will start. What is my pelvic health? What is pelvic health?
Well, first of all, thank you very much for having me, Faiza and Salam Radio. It's really an honor to be here and speak to our community members today. So if we think about what pelvic health is anything to do with the organs that are in our pelvis. So that can be our bladder, that can be our bowel, for women specifically. That can also include any symptoms to do with the vagina. Now, as we know, pelvic health can be either a problem or cause us concerns at any stage in our life. We can possibly be born with something that is different in our pelvis or affects our pelvic health, or we can develop problems as we go on throughout life. And as we will talk later in the show, different parts in our life will be affected in different ways. But just briefly, it can be symptoms including, for instance, with the bladder, urinary incontinence, or it can be something to do with recurrent urinary tract infections or just bladder pain. It can also be to do with the bowel, so struggling to go to the toilet to empty your bowels, constipation, or even fecal leakage.
Thank you so much for sharing that with us. And the first thing I would like to know is, does this impact just women?
No, it definitely does not. So it affects women probably more than it does men, but it can affect anyone at any stage in their life. Because our anatomy as women is slightly different to that of men. And of course, we are special because we have to be able to give birth to babies. And because we are designed to be able to give birth, our anatomy is probably affected differently to that of men. Also, we have a lot more hormonal challenges throughout our lives, and that can also quite significantly affect your pelvic health. And again, as women, we obviously have monthly hormonal changes, and if we become pregnant or when we go through the menopause, we have quite significant changes in our hormone levels. And unfortunately for us, it also affects our pelvic health.
That's a lot. So let's start with how it impacts us during our pregnancies.
So during pregnancy, the first thing to note is that we have quite a few extra hormones. So some of the ones we normally have, like estrogen and progesterone, these levels would increase throughout pregnancy. And that is to support your pregnancy to grow and to be healthy. But we also have another hormone called relaxin. And relaxin is involved in sort of relaxing tissue, so preparing the pelvis to be able to go through a normal vaginal delivery. But unfortunately, relaxin is sort of released throughout the body. So it doesn't only affect specifically the vaginal region, it will affect the whole pelvic system. And that's why women might also mention things like pelvic girdle pain or lower back pain during pregnancy. We know this is also related to the relaxin release. Now, specifically in pregnancy, again, first of all, we have this hormone release, so the muscles are probably a bit more stretchy and they give a little bit more than they would have done before. But on top of that, we all of a sudden have a baby growing in our womb, and baby gets bigger and baby presses more onto the pelvis, which means the pelvis is now under a bit more pressure, and that includes your pelvic organs. Because, of course, your womb is just above the bladder, so there would be more pressure onto the bladder. Also, it takes up up space in your abdomen. So the bowel sort of needs to move out of the way to make space for baby to grow. And all of this puts your pelvic floor at higher risk of possible dysfunction.
Interesting. So when women tell us when they're pregnant, oh, I laughed and I peed a little bit, or when I was jumping, I peed a little bit.
Exactly.
In pregnancy, is that expected because of the weight of the baby, or what should you expect in pregnancy regarding that function?
So there will definitely be extra pressure on the bladder. So I think symptoms such as what you just described is something we would call stress incontinence. So stress incontinence is when we leak a little bit of urine when we either cough, sneeze, laugh, lift something heavy, move something, pick up a toddler, lift the car seat. And then we get a different type of incontinence, which is what we call urge incontinence. And that is when we struggle to hold on. So the bladder feels full, we need to get to the toilet. But in trying to get to the toilet, we've already had an accident. You can have one of the two, or you can have both of them a little bit together. So we can have mixed incontinence. But as you just described, is it normal? No, it is never normal. It is never normal to have an accident with your bladder. It is common. But it being common doesn't mean that we should accept it as a normal symptom. We should recognize that the body is trying to show us that it's either struggling to cope with the load that's being put on it, or that there might be a slight weakness. So the sooner we can identify these symptoms and speak to someone about them, hopefully the sooner we can do something about it.
And interestingly, what I'm thinking whilst you're talking is, if you happen to possibly have a pelvic floor that isn't as strong as it could be, if you happen to become pregnant, you're probably going to notice that more, right?
Yes, definitely. You're going to notice it more because the pregnancy itself is going to put you at higher risk, and there's going to be more work to be done by the body while you're pregnant. But also, as I mentioned, the hormonal changes, and that will make it more difficult for your pelvic floor to function as good as it did before you were pregnant. Now, what we should and what we would like to see happening, which was part of our perinatal pelvic health initiative, is we want women to be screened. When they say, I'm coming for my first pregnancy appointment, I'm going to see my midwife for the first time, we want ladies to mention that I've noticed this symptom or that I've been symptomatic with this.
How interesting. How do women actually know that it's a symptom? And how can we raise that message for them? Because so many mums I meet, they casually joke about it.
Yes.
But actually, it's not that funny when you really think about the seriousness of it. And as your body changes, we know that our hormones are going to change. And with age, it might get worse for us. So it sounds like it's easier to nip it in the bud sooner.
Definitely, definitely. So as part of the perinatal pelvic health initiative that was rolled out about 2 years ago and should now be part of baseline service in NHS, meaning it should be there across all areas within the UK. But really what we were wanting to achieve is we wanted to make sure that, first of all, we can try and mitigate any injuries. In terms of healthcare professionals, we need to try and stop any injuries to women or any trauma to women while they are delivering, so that we can hopefully prevent pelvic floor dysfunction in the future and during the postnatal period. But the second big thing for the Perinatal Pelvic Health Initiative is that we want to empower women with knowledge. And I think that's really something that we are doing today. Talking about these difficult discussions openly is how we're going to empower women to say, no, actually, this symptom I just experienced is not quite right, and I should be able to speak to someone. It is, though, a very difficult topic, and it still feels like a topic that is quite taboo and comes with a stigma. Women doesn't really want, well, first of all, we laugh about it, but it's not really something we would discuss over coffee with a friend necessarily. We might, if we've known that person for a long time. But it's also sometimes even difficult for women to discuss with their partners. In most cases, partners don't even know that women are seeking help for these types of conditions because we just feel so ashamed about them. So I think a lot of work still needs to be done. We hosted a women's wellness event last year in Queensgate in September last year. And part of that project was to try and reach out to our community in an environment where it's not hospitalized, it's not clinical. There was information stands, there was live presentations, and it's events, I think, like that. Things like this, talking on a radio, having a sort of relaxed discussion about these topics that will really give women the knowledge then to care for themselves and to seek advice or assistance where it is available.
I hear you, and such important points that you've made, and that probably leads me on quite nicely onto, we've spoken about pregnancy, what changes you can expect. Can we talk a little bit more about the birth? How does the birth actually impact your perineum? And I'm going to highlight both a vaginal birth and a cesarean section birth.
Okay. So let's start with comparing the two. So there is evidence to suggest that with a vaginal delivery, there might be a higher risk of tearing. We know that women that go through a vaginal delivery could have a potential tear, and I'll talk a bit more about tears in just a second. But they could also require an episiotomy to make it easier for the birthing process to occur. So as we know, an episiotomy is a small incision that gets made sort of in the doorway to the vagina, into the sort of to the side of the perineum, not into the perineum itself, but to try to stop any further trauma from occurring. So when we do an episiotomy, we know that woman might potentially be at risk of having a more serious injury, which is why we offer an episiotomy. So in terms of a vaginal delivery and a cesarean section, there is a slightly higher occurrence of pelvic floor dysfunction in vaginal deliveries. However, it is not a significant difference. With cesarean sections, we still have women who end up with pelvic floor dysfunction subsequently. So we need to recognize that probably the biggest impact from pregnancy is the pregnancy itself, and the weight of the pregnancy, the duration of the pregnancy, and the changes of the posture, the body's posture, as well as the hormonal changes. So statistically, there's not a significant difference between the two, so that we can say one is safer than the other, for instance, which is why we still advocate for normal vaginal deliveries, and most women are quite happy to go for that. And of course, if there is a need for a cesarean section, we will consider that. But if we come back to vaginal deliveries, the risk for vaginal deliveries comes from a big baby. So if we have a baby that is more than 4 kilograms, of course, if we have a baby where there's a slightly odd positioning, so maybe arm comes out with the head, for instance, and we need to make room for that delivery to occur. Prolonged pushing, so women that have to push and push and push. And if I say prolonged, for at least more than 2 hours, so then we start to think, the body's worked really hard for a very long time. The body almost doesn't have anything more to give. And that is when that area becomes at risk. And then any instrumental deliveries. So people may have heard of forceps deliveries or a ventouse or a suction cup delivery. And again, any instrumental delivery usually comes with a risk because it needs to happen quick. We might be worried about baby at that time. So things generally happen very, very quickly. Or we might also offer an episiotomy at the same time. Now, if there is a tear of any sort, so second-degree tear, the midwife will suture in the room. If there's a third or a fourth-degree tear, we do take those quite serious, and women will need to be taken to theatre to be sutured there by a consultant.
Okay, interesting. And you said it's quite common for women to have some form of perineal tear if they have a baby vaginally. What does that look like in a number? How likely is any one mother to have at least a type of tear, and how many of them might end up with a much deeper tear, like a third-degree tear?
So we know that first-time mums are at higher risk because, of course, the body's never done it before. If you've suffered a tear in a previous delivery, your risk of having another is about 7% in a subsequent delivery. And we do need to consider in subsequent pregnancies that you've had a tear. We do want to know about it. So again, this is something women should offer that information on. If the midwife is not already aware, it's definitely something a woman should specify, that I had a tear in my previous pregnancy. Because we do want them to see a consultant at least once throughout their pregnancy to discuss mode of delivery, to see, is a vaginal delivery still the best course for me to take in my next delivery? What is the risk of me suffering this tear again? Also, we know that some ethnic groups are more at risk. So we know our Asian community is more at risk of a tear during a vaginal delivery, as well as our African communities. Generally, they have shorter perineal bodies. And what I mean by this is the space between the back of the vagina and the start of the back passage opening. That little bit of skin for the Asian and African ethnic groups is just a little shorter. And the shorter that is, the more at risk it is of tearing during a delivery. So for these ethnic groups, we have to we have to take extra care, really. And again, I think we need to empower them very, very well in terms of what can they do themselves beforehand or during the pregnancy, and how can midwives look after them. Because I think it's really important that these women know, what can I ask for during my delivery so that I know every little bit of care is taken to make sure that I do not tear. Of course, tears might still happen. We cannot stop all of them. But I think we need to be able to say we tried our very best and we did everything. And if they then still happen, it is a very unfortunate event, but we all try our very best to look after you in terms of your aftercare.
I hear you. I want to go back to your point that you made about South Asian communities and Black communities having slightly shorter perineums, and that you've observed, is this across the UK, that they're more likely to just generally have deeper tears?
It's across the world, really. It's everywhere. Because in a lot of Asian countries for many years, episiotomies was part of their delivery strategies. And it would be interesting to see, the data would be interesting in terms of now that we do not routinely do episiotomies anymore, because we now do episiotomies only depending on need. So if we observe the perineum during delivery, we will then see when do we think this is needed, rather than just doing it in case. Because again, an episiotomy is still regarded similar to a second-degree tear, so it's still a quite deep tear. So we've sort of now moved on from doing them routinely to being selective of when we do them. But historically in Asian countries, they were just part of normal deliveries. Everyone used to have an episiotomy. So I think for a long time, we probably didn't realize that actually those episiotomies protected them to a degree from the tears. So it's only now that as we're trying to change birth regulations and how we do these things, that we're realizing actually there really is an impact on these communities.
I hear you, and that's interesting, because I can definitely speak back home for my family, that the families that have money to be able to afford care and go into hospital, they will go into hospitals and give birth there. But quite a large proportion of my family members often gave birth at home with somebody that was a safe birth attendant. And if they had some sort of perineal tear or trauma, it was very much left to heal by itself. So there probably wasn't much data collected, or there's nothing really documented to know exactly what's been happening there. Now, you mentioned it used to be routine in the UK to offer episiotomies to all women, and I remember this practice, or I've read a lot around this practice. Can you explain why they stopped doing it routinely to all women?
The reason they stopped doing it routinely is because it still influences the pelvic floor negatively, in a way that negatively we should put in inverted commas, because we are causing an injury. So episiotomies are there to try to prevent a more serious injury, but in effect it is still an injury. Now, it is an injury that is controlled, and it is an injury under controlled environments with, these days, a very special pair of scissors that measures exactly where that episiotomy needs to happen, and it's exactly at the right degrees. But really what we're trying to do with an episiotomy is take the potential risk away from the anal sphincter. And we'll talk about that in just a second if you want, in a bit more detail. But the whole point is, a tear usually happens from the back of the vagina to the anus. And what we want to do with an episiotomy is we want to take it away from the anus. So we're taking it a little bit laterally. It's difficult to describe, but it's sort of going in a diagonal rather than straight down. So we're trying to direct it to a safe zone. However, we sort of need to sometimes reevaluate and think, was it necessary? And in some cases, you have to think, was it really necessary that we did this episiotomy? We did prolong this woman's healing process, of course, with any type of surgical procedure. And this is an injury, but it's created in a surgical manner. It still comes with the risk of infection, and it still needs to heal. There might be aftercare that we need to give this person that comes at a cost. But also, ethically, we need to think, can we prove that it was really helpful and did change matters? And it was for that reason that people stepped back, because really we couldn't prove that it prevented all trauma, it prevented all dysfunction. And now really we think about episiotomies to try to prevent an obstetric anal sphincter injury, which is your 3rd and 4th degree tears. And we try and do an episiotomy if there's an instrumental delivery. Because of course we're now introducing an instrument into the vagina alongside baby's head.
I hear you. And you've just mentioned first degree, third and fourth degrees. For people who are listening, can you explain what you mean when you're using this terminology?
So any vaginal tear during delivery, there's 4 categories. So there's a grade 1, grade 2, grade 3, grade 4. So a grade 1 tear usually is not even mentioned to you. They might say a skin graze. It might need 1 stitch, if that. And actually, it heals very well just on its own. We then get a second degree tear, which is a tear that goes from the back of the vagina towards the anal sphincter, but it does not reach the anal sphincter, but it does reach the pelvic floor muscle bulk. So it still requires suturing, and usually this happens in the room by the midwifery staff who's quite competent in suturing these. And then they will still need a little bit of recovery afterwards. So they will need some pelvic floor support. They would sort of be giving them advice in terms of opening the bowels, etc. So we still take these quite serious. Now, your episiotomy falls in the same category as your second degree tear. So if we think about episiotomy, you almost need to think, if I had one, I need to look after myself in the same way as somebody that would have had a second degree tear. Now, the more serious ones are your third degree tears and your fourth degree tears. So your third degree tears, we subclassify as 3A, 3B, and 3C. So a 3A tear means that it comes from the back of the vagina to the external anal sphincter. So that's the outside muscle in your back passage, the one that you can squeeze. So if we said hold on to wind, that is the muscle you'd be squeezing. So this tear involves that muscle, but less than 50%. A 3B involves that muscle more than 50%, and a 3C involves that muscle as well as the inside muscle of your bowel. Now, a 4C is the most serious one, and that involves back of the vagina towards the back passage, the outside muscle of the bottom, the inside muscle of the bottom, as well as your rectal mucosa. So this is quite a serious tear, and we do want to make sure that this is sutured by somebody that's quite competent. And for that reason, third and fourth degree tears are always sutured in theatre.
It sounds like it's very important that it's done that way, so that, and I'm sure we're going to talk about this a little bit more as we move forward, so that it can make sure that women's bodies recover from such an extensive tear.
Exactly.
Because I guess if you leave it, and it is an extensive one, what kind of side effects would that cause to women's health? Yeah,
definitely. So when we are in doubt of a tear, as in terms of classification. So if we're not sure if this is a deep second or a superficial third, really we should be treating it as a superficial third. We should almost overestimate it rather than underestimate it. Because unfortunately, the side effects of injuries to the anal sphincter complex can be quite debilitating for the rest of your life. Now, just before we talk about the impact of it it's quite important to understand how it works. So we have 2 muscles in the back passage, an inside one and an outside one. And the inside muscle, you cannot squeeze yourself. So the inside muscle is under the control of your brain. But it's an extremely clever system. I'm always amazed when I think about how we were designed in such a way. But the inside muscle is a little bit like a muscle that goes to a food tasting. So it has a sampling reflex. So as the stool comes down from the rectum towards the anus, you can feel that something's coming. So it tells you what's coming. It tells you, is it feces or is it wind? And you have the time to decide, this is an appropriate time for me to let go of this wind, or I need to hang on because I'm in a public space. Or alternatively, you will know this is solid stool, I can hang on, or this is watery stool, I need to rush to the toilet. So it gives you an idea of what is on the way. Now, should you decide this is a good time for me to go, it will relax. And you can either let that wind pass, or you can sit down on the toilet and you can defecate or open your bowels. If you decide, no, this is really not a good time, it will start to increase its tone and it will close the opening. And whatever that little inside muscle is doing in terms of what your brain is communicating with you, the outside muscle supports that. Now, the outside muscle is under your control. You can squeeze it. If I say to you now, squeeze your outside muscle of your back passage, you'd be able to squeeze that. And if I say to you, let it relax, you'd be able to do that. So if we have an injury to one of these muscles or to both of these muscles, the side effects that you mentioned can be either that we have control, but we have a lack a lack of it in such a way that we can control it, but we need to rush to the toilet very urgently. So we can hang on, but every bowel motion is really urgent. And we always feel like I cannot venture away from home unless I know where a toilet is. Or I cannot go away from home unless I've already been to the toilet today. Now, the next thing is you can also have leaks. So you can either leak wind or you can leak feces. And that is quite debilitating. And sometimes you know it's coming because that sampling reflex is still working a little bit. But sometimes if that sampling reflex isn't working, you might only know you've had an accident either when you see it or somebody else tells you about it.
Wow. Oh my goodness, Lisa. I have just learned so much from listening to you, and we are going to be going on to an ad break soon. It's been half an hour already, and I'm sure anyone out there who's either been pregnant or is pregnant, who knows of someone who's struggling when it comes to their pelvic health, needs to share this show for them to listen to. Now, if you'd like to connect with us, please know that you can text or call in on 01733 602 133, or you can email us on info@salamradio.co.uk. We will be back after this short break.
You're listening to Salam Radio, and it's now time for Zohar Azan. This Azan is sponsored by UK Islamic Mission, serving humanity since 1962.
Allahu Akbar, Allahu Allahu Akbar, Allahu Akbar. Ashhadu an la ilaha illa Allah. Ashhadu an la أشهد أن محمدًا رسول الله. أشهد أن محمدًا رسول الله. حي على الصلاة. حي على الصلاة. حي على الفلاح. حي على الفلاح. الله أكبر، الله أكبر. لا
الله أكبر، الله أكبر، لا إله إلا الله. اللهم صل على محمد وعلى آل محمد كما صليت على إبراهيم وعلى آل إبراهيم، وبارك على محمد وعلى آل محمد كما باركت على إبراهيم وعلى آل إبراهيم في العالمين إنك حميد مجيد. اللهم رب هذه الدعوة التامة والصلاة القائمة آت محمدا الوسيلة والفضيلة وابعثه مقاما محمودا الذي وعدته. اللهم آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. اللهم بك نحيا وبك نموت وإليك المصير. رضينا بالله ربا وبالإسلام دينا وبمحمد صلى الله عليه وسلم نبيا ورسولا.
اللهم صل
You're listening to Peterborough's community radio, Salam Radio. Salam Radio. 106.2 FM.
Right, you are back to Salam Radio 106.2 FM. We welcome anybody who's just started listening. I am with the lovely Liesl today, who's a physiotherapist, and we're talking about pelvic health, which is such an important topic. If you know anybody in our community who has had a baby, is struggling with their pelvic health, and it can start off small, symptoms of incontinence, not able to control their bladder or bowels, please tell them about this show, because we need our women to have a healthy pelvic floor. We want them to have healthy, long lives without side effects caused to them, possibly because they've carried a baby. So Liesl has been talking quite a lot to us about what that might look like, what impact birth or pregnancy can have on your pelvic health. And I want to probably move forward a little bit more and talk a bit more about what can women actively do, Liesl, to try and reduce the chance of getting a perineal tear.
Okay, so the first thing I think is when we fall pregnant, we should think pregnancy, pelvic floor. So as soon as we fall pregnant, we need to think, I now need to prioritize my pelvic floor for the duration of my pregnancy. And if I plan to breastfeed afterwards, for the duration of breastfeeding. And then really we should be checking in with it sort of once a week for the rest of our lives. So once we put our body through such a significant change, we should really be prioritizing our pelvic floor. So that means empowering yourself with how to do these pelvic floor exercises. And again, if you want to talk about it a bit later, Faiza, then we can. The other thing is there's some evidence to suggest that self-perineal massage done towards the end of pregnancy can be helpful to prevent a tear from happening. So women with a low-risk pregnancy can start this from 36 weeks onwards. There is quite a lot of data available on the RCOG website, so the Royal College of Obstetricians and Gynecologists. They have a section on their website, the Perineal Hub, and there is quite a lot of data on there in terms of perineal massage. If you have a high-risk pregnancy where you are under consultant care, please do not start this unless you've spoken to your consultant about it and you've been given the all clear. If you're going for a caesarean section or it's a planned caesarean section, obviously this is not necessary. But if you are planning a vaginal delivery, this can be really helpful. Now, it only takes about 5 minutes, and we do it 2 or 3 times a week. And you don't need any special tools to do it other than an oil or a gentle lubricant that you can do the massage with. And other than that, you just need your thumbs. And we do it 1 thumb at a time. So really nothing that you need to invest in other than taking a bit of time and a bit of time for yourself. Now, other than that, I think women need to know what they can ask for in terms of support during the delivery of the baby. And again, there is a clinical guideline that's been published to say that we should be saying to women that they can ask for things like a warm compress during delivery. So that means the midwife will be applying this warm compress, or potentially your partner could be involved, your birth partner. And also we want the midwives to really visualize. So look at the perineum. So we almost want women to ask in their birth plan for the midwife, can you please regularly observe and look at my perineum to see if you can see that there's any skin changes. Now, midwives will be trained. They know exactly what to look for. But I think women often feel like they are maybe left a little bit to their own devices throughout delivery, and we just need to make sure as healthcare professionals that we listen to women, but also we need to give women the information to advocate for themselves. So very important, visualizing the perineum, looking at it. Because this means that midwives will know when and if it is necessary to do an episiotomy. It might not be at all. Let's hope it's not. But if it is necessary, we will know at the right time, before it becomes very quick, high risk, all of a sudden an emergency. And the other thing that is that we're doing a lot of teaching on at the moment, actually, for midwifery staff, is that we should be doing and should be supporting perineums hands-on. So ideally, we would like women, if they want to have that extra support for the perineum throughout delivery, to request that they can have hands-on delivery. So that means the midwife's hand is on the perineum, one hand supporting the perineum and one hand very gently supporting baby's head to make sure that baby's head is coming through the opening at a speed that is controlled, rather than baby moving through the opening very quickly. Because we know these tears often happen when births are very rapid. Very suddenly, baby moves his or her head or the nose or the occipital bone, the back of the head, and then all of a sudden these tears can occur. Or, of course, when it happens, when it takes a long, long, long time and it's a prolonged labour.
I hear you. Such interesting things to share, and I hope people are finding this useful. I'm also curious just to touch a little bit on what other things can mums do during labour regarding their position, and say, for example, when labour's been started by an induction, because we know this can impact the mode of birth.
Yes.
So can we talk a little bit about that, because these are things that you have control over as a person who's having a baby?
Yes, definitely. I mean, sometimes it's difficult in terms of positioning, because depending on if baby needs to be monitored. Often if baby needs to be monitored, we are told that we need to stay on the bed. But being in that supine position, so being on your back, is sometimes not that helpful in terms of delivery, because it slows the process of delivery down. Things might take a little longer. We would ideally like women to be in an active labour position, where they are maybe on all fours, where they are upright sitting, bouncing on a ball or leaning over a ball. So there's a lot to be said for trying to keep the women as active as possible throughout their labour. Of course, it's not always possible, but as and when it is possible, we should try and do that. Another thing that is available is the birthing pool. Now, the birthing pool, unfortunately, we don't have enough pools to allow to cater for everyone that is in labour at the same time. But if it is available and that is your choice of delivery, then that would also be a good idea, because there is some evidence to suggest that water will actually help the skin to stretch better. It is worth taking note, though, that if you are in the water, it is sometimes very difficult for midwives to be able to give you the hands-on support on the perineum, just because of the positioning you find yourself in. So because you are in the pool, you are submerged in the water, it's very difficult for them to actually give you the perineal protection that you need. But sometimes that's just weighing up the risk. And again, as we said before, looking at that perineum throughout the labouring process.
I can definitely say that from my experience of working as a midwife, and I've only ever really dealt with the parts when people are having babies. I'm very passionate about that, and hence why I'm so glad that you've come on, because I think more and more people need to hear about this. I think far too many women are sat out there with pelvic health problems, not necessarily knowing or aware that they should really be talking to somebody about this, and it's a problem. And I truly believe that it's when we're probably going to hit our menopause where we're going to really feel the impact of it. So if you're listening, please reach out for help. There's lots of places you can go to, and we're going to talk a little bit more about that. But my experience has been exactly that, Liesl, that when women are upright, forward and open, and they're in positions where they are more active in their labour, that their second stage of labour is shorter. So their pushing stage is much shorter. And B, the perineum seems to stretch so much more easily. So I would advocate that. That's been my anecdotal experience as a midwife. Yeah. If you're upright, forward, open, you don't have any medication that's slow down your labour, and your body's self-managing labour, that it seems to be doing it more efficiently. And of course, if there's a need, then your healthcare professionals will talk to you about offering you intervention. But it's definitely something that ask questions about, because everything that we medically do has a side effect.
Definitely. And I think also for women, sometimes during the labour process, we just, you'd know what I talk about, but we sort of get in a zone. We don't really hear what's being said to us. We cannot really have a proper conversation at that time, because we're so zoned in. We just focus on this one objective that we have, and that is to give birth to this baby. We also probably need to empower our partners with that knowledge, because our birth partner is not just there to share that experience with us, but also to advocate for us. So it's really important, whoever's your birth partner, if that's your husband, if that's your partner, if that's your mum, your sister, a friend, but for them to know, this is what I would like as my birth. this is what I would like for them to do for me throughout. This is how I would like for them to support me. So that if you cannot speak up for yourself at that time, there's somebody else that can just remind gently to say, this is what she would have wanted. Can we look at this again? Because as we know, if we're on gas and air, potentially, or maybe we have an epidural and we just feel like we feel no discomfort at all, then sometimes these things might take a bit of a back seat. But somebody else mentioning them, I think, is quite powerful.
So it's really interesting because there's two schools of thoughts that keep your hands on and don't touch somebody's perineum at all. And interestingly, when I went to this place called The Farm in America, I think it was in 2014, it's been 10 years, I visited this lady called Ina May Gaskin, who's a really well-known midwife, and she came up with what we call the Gaskin maneuver, go onto your hands and knees if you have a baby that's a little bit stuck. Now actually used all across the UK in our shoulder dystocia pathway. But one of the things that they actually did do was they were very hands-on as midwives. And I found that really fascinating because I always felt quite torn as a midwife in the UK. Am I supposed to? Am I not? And I have felt over the years, women ask, it's okay, you can. Some women are very forthright and say, no, I definitely don't want that. And and that's cool. We stand where you stand. We're right next to you. You're guiding it, we're listening.
Exactly.
But it was really interesting going to this farm where it was seen as quite a hippie community to go to, and they do everything low risk and natural. And actually they were very hands-on, and they used a lot of lubricants to massage the area, even throughout labour. And that was really fascinating for me to see. And actually something that I know my communities do back home. They don't talk about it openly, but I know it's done.
And it's done in the African communities as well, especially in Northern Africa. There's communities there that massage throughout, and the midwife will actually do the perineal massage in labour to try to support the woman and prevent a tear. So I think in terms of positioning, definitely we now know as much assistance as we can get from gravity and your natural postural position in terms of the pelvis and the coccyx, your tailbone, that makes absolute sense to give birth in a more upright position. And it just keeps things moving at a good pace. As you said, if there's other medical intervention that's required, I think it should be discussed at the time on the day. But in terms of hands-on, hands-off, there's been a lot of research done, especially in Scandinavian countries. And we know hands-off came about after a study that was published in the UK. And we sort of changed all of our practice according to that one study. Unfortunately, since then, we have come to the understanding that the data was skewed because of how the data was interpreted. So even though at that point in time it seemed the acceptable practice, I think what we now need to consider is we should probably see what the women want. There's evidence to suggest that if we can protect the perineum with our fingers, with our hands, that actually we have lesser risk tears. And that is really important because we don't only look after that woman today, we need to look after that woman for the rest of her life. She's going to live with this one perineum for the rest of her life.
You don't get another one, do you,
We don't
Lisa?
get another one. There is no repair. There is no replacement. Yes, we can try and fix things wherever we can, potentially. But really, we need to think, if we care for this mum in her pregnancy, her perineum during delivery is just as important as us looking after that baby.
Absolutely, because the longer term effects, especially with the extensive tears, and I think this is important to note, when we talk about the longer term complications, they come from the more deeper tears, don't they?
Yes, they do. If we talk about bowel symptoms, so if we talk about wind incontinence, stool incontinence, so fecal incontinence, or if we talk about bowel urgency, your deeper tear is your risk factor for that. And as I mentioned before, unfortunately, there's very little that we can really do to fix them because, again, they're quite special in how they were made and designed. And we haven't really come up with a replacement for them yet. So physiotherapy is a key component of trying to get back some of that bowel function that might be reduced after a tear. And these women would get routine physiotherapy appointments and they will be seen in a perineal trauma clinic. And that should be the same across the board now in terms of the Perinatal Pelvic Health Initiative. It was a key component to say that we need to have dedicated clinics for these women to be seen in so that we can really identify problems if there are problems. It's also important to say not all women with a third or fourth degree tear will have symptoms. Some women do absolutely fine for the rest of their lives. But what we need to make sure of is that we pick out those few women that struggle. And we do not need to wait for them to speak up. We should try and sort of risk assess them throughout their recovery process. But it's also worth saying that you could go through a pregnancy absolutely fine, not even a tear, not even a grade 1 little graze, and you could still end up with something like a mild bladder problem, as in a bit of stress incontinence, as we said before. Or you could have a bit of symptom of vaginal heaviness. It just feels like the vagina doesn't feel the same as it did before you had your baby, and there's a bit of dragging, there's a bit of heaviness, or when you palpate the area or when you clean yourself, you just feel like it feels different. I feel a lump where I didn't feel a lump before. What is that? And for that, you don't even necessarily have to have a traumatic delivery. It is just tissue changes and tissue weaknesses that might be secondary to you having had a baby.
That's so important to note. It's not necessarily about having a tear. It's about having a baby, carrying a baby.
Exactly.
That is the key component that changes our pelvic health. And I guess what I want to move on to asking you is, we only have 15 minutes left, can you, in a nutshell, explain what does it actually feel like after you've had a baby? Because we absolutely experience a difference in our pelvic health in those early days, weeks. What does that feel like? And what is normal and what is not?
Okay, so if we speak about what it will feel like, and this is what it will feel like, what should be normal. For the first few days after a vaginal delivery, we will feel heavy. We will feel a little bit like all of our insides might want to move down or might want to fall out. Now, that is quite a normal feeling for the first week to 10 days. But after that, that feeling should gradually be reducing, and it should get better and better and better. And by about 6 to 12 weeks, you should start to feel like actually my whole area, my pelvis is now starting to feel a bit more like it did before. It will probably not be perfect yet because you might be breastfeeding, and breastfeeding slows down the recovery process in the pelvis. Not because it's a bad thing to breastfeed, not at all. We do still want you to breastfeed. But it just slightly reduces your estrogen levels in the vagina, and the vagina needs estrogen to repair itself. So it might take a little longer if you breastfeed, but just stick with it, it will get there. Now, generally, we expect pelvic floor feelings of heaviness, maybe mild incontinence, things like that you might experience after labour to get better and be resolved by about 3 months, 3 to 4 months after your delivery. Now, that is if you are following a textbook recovery process. Now, we all know it rarely happens as it does in textbooks, so you probably will need to do, and you should be doing your pelvic floor exercises during this time. You should be thinking, I'm going to prioritize these exercises. That part of my body has been through a lot, and I need to take extra care. A bit like brushing my teeth. Twice a day, I brush my teeth. Twice a day, 3 times a day, I do my pelvic floor exercises, and it is a priority. Now, if you feel during that period of time the heaviness doesn't get any better and it just stays the same, if you experience incontinence and you think again it just does not get any better, I'm still leaking every day, I'm using 3 or 4 pads a day, I'm struggling to reach the toilet, or I'm struggling to go to the toilet, and that is either for your bladder or your bowel. Or it's really painful to go to the toilet because I have really bad piles, or I think I might have a slight anal fissure. Any of these symptoms, by about 3 months, we want you to speak to someone. Now, recently, we've opened a self-referral at the hospital, so you can self-refer during the first 12 months after you had a baby. You can self-refer while you're pregnant as well, to the Women's Health Physiotherapy team at North West Anglia, so that's Peterborough City Hospital. You can also self-refer if you are giving birth in this sort of Huntingdon area. You can self-refer through Dynamic Health, which is another physiotherapy team based in the community. And if you are based a little bit further along towards Cambridgeshire, you can also self-refer to Cambridge University Hospitals. They also have a self-referral. And we want women to speak up about these things. It's never a waste of our time. If we have one conversation with you and we feel actually you'd be fine just doing your exercises on your own, you know exactly what you're doing, it's still a win for us because we've been able to reach someone, we've been able to have that conversation, and the person knows where we are. They will not be scared to speak up again if there's anything else.
And also the person will probably talk to their friends and family and say,
Exactly.
you know what, Lisa is kind of a good person to go and talk to. Please go and talk to her.
Exactly, and that's what we want.
How do you actually self-refer though?
So there's a link on the website. So if you search NWAFT, so that's NWAFT, NWAFT, self-referral, physiotherapy, women's health, you will find the link. It comes up on the website. And if the page opens, it's just towards the right side of the page and it says self-refer. And you just open the form and it goes through Microsoft and you fill in the form and we receive it and we'll get in touch with you.
And how
for an
soon after
appointment.
the referral do you tend to get in touch with them?
It depends. If it is a woman that's less than 25 weeks pregnant, it is a routine appointment. Anyone 25 weeks and over would be an urgent appointment. Urgent, not because we're worried about the symptom. Urgent because we want to see you before you have your baby. And then anyone after that, as I mentioned, your third and fourth degree tears would be referred by the ward anyway. So they do not need to self-refer. But if there's anyone with a second degree tear or anyone with bladder symptoms or any bowel symptoms that they're worried about, probably about 6 weeks.
Can you just explain a little bit about the mums who have probably got after 12 months? Because I'm just wondering about those mums who finally are seeing a light at the end of the tunnel.
Yes, of
They're
course.
kind of getting their life back. Their body's starting to feel like a new normal.
Yes.
So where can they go to? Because I know that that's the category that I think is sat out there
Yes.
who might be listening to this.
Absolutely. And that is still where there's probably a bit of a gap in the service. And we are hoping that over the next 2 years, we would be able to open self-referral for everyone across the board. So anyone with any gynecological or bowel issues in terms of their pelvic floor would be able to self-refer. But at the moment, it's a little bit considering if we open the floodgates, and unfortunately, the more awareness we create for these things, the more people step forward, which is great, but we just need to make sure that we can catch people and support them well. So we haven't opened that just yet. At the moment, it's open for pregnant and postnatal ladies. But for the time being, towards dynamic health, they can self-refer at any stage. So it's not only for their during the pregnancy or postnatal. So the dynamic health team can accept that referral. Alternatively, women can speak to the GP or to a nurse practitioner at the surgery and just request a women's health physiotherapy referral.
Okay, that's really, really important information then. I hope people find that useful. We are definitely getting towards the end. We only have 9 minutes left, Liesl.
Went so quick.
It's gone so quick. And I still feel like there's so much more that you could share with us. I want to ask you, what is your role as a physiotherapist? What do you actually do when women come to you? What does that look like?
And again, I think that's really important because I think the more women know what to expect, the easier it is for them to go to these things. And exactly the same with delivery. The more we know what to expect during labour, the easier it is. So what we do is if you contact us, we see you. And for the first appointment, usually you have about an hour with us. Now, depending on the symptom that you might describe in your referral or that is maybe given to us, we might decide to do the first appointment over the phone. And that's either because maybe you are a bit far away or somebody might say, actually, this is a difficult time for me because it's school pickup. Can I just have an appointment over the phone for the first time? So we take a lot of history in that first appointment. Lots of questions, specific details about what symptoms you have, how long you've had them for, other medical conditions, obstetric history, just lots and lots of questions. And then we may, if you see us face-to-face for the first appointment, or it might be in a subsequent appointment, but we will always offer you an internal examination. And what that entails is depending on the symptom. If your symptoms are purely bladder-related or vagina-related, we might only offer you a vaginal examination. Now, that is not exactly the same as a consultant appointment. We do not generally use speculums in our clinic. If you go to the perineal trauma clinic, you might have a speculum examination there. However, generally, it's what we call a digital examination. So it's a finger assessment. So what the physiotherapist wants to know is, can she actually feel something that is or might be causing you a problem? And what is the pelvic floor doing? We really want to know, can that pelvic floor squeeze? And if it can squeeze, how strong is that squeeze? If your symptoms are more bowel-based, we might offer you a digital rectal examination, so a finger examination, but of the back passage. We might offer you both.
Okay.
We will also generally not discharge you after the first appointment. As a rule of thumb, you would probably see us again because, of course, we now have done an examination. We have a baseline. We now want to see you get on with your exercises and then see you again to see has there been any change in your baseline. Are you better? Is your symptoms better? So with us at NWAFT at the moment, we will offer you a follow-up. It's not really a question of would you like to come back? We will say we do want to see you again.
That's so important to do, to keep that doorway open.
Yes.
Because it's likely that a lot of women in our communities will say, okay, she's seen us, she's helped us now. And then you think the problem is solved. But actually, it's good to have that
Yes.
follow-up just to make sure things are definitely going in the right direction.
Exactly. We would definitely want to see you again.
Thank you for sharing that with our listeners. And we are definitely getting closer to ending. And I just wonder whether, just off the top of your head, there is anyone that you've ever met where your service has made a difference to them, that may have had a baby, that possibly had an extensive tear, and if you'd be able to share, any kind of feedback that you may have received.
Yes, there's one lady that comes to, well, there's obviously been a few, but there's one that comes to mind just because I think we made quite a significant impact for her. She was also from the Asian community. She suffered a 4th degree tear. And unfortunately, after she suffered a 4th degree tear, she was told that she was quite lucky to suffer a 4th degree tear. But she subsequently suffered a fistula. And a fistula, unfortunately, is a little hole that you can have between the vagina and the back passage. And unfortunately, she then had little bits of poo coming through the vaginal opening. So that was quite worrying for her at the time and quite upsetting. But we were able to, through the general surgery and the colorectal team, we were able to support her. She's also done some pelvic floor rehab exercises. And I'm happy to say we've now discharged her and she's had her second baby through cesarean section. But she's doing very, very well and she no longer needs us.
Oh, fantastic. And what an amazing story to end on. Somebody that needed help, had a service provided to them and had a good outcome. Now our show has actually come to an end, so I just want to say anybody that's listening, know that we are going to come back in 2 weeks' time, and if you need to connect with us, it's 01733 602 133, or you can email us at...
Stay tuned to Salam Radio after this short